Hello, everyone. Welcome to this installation of the Rodham Impact Speaker Series. You're probably thinking, okay, where's our beloved Dr. Gigi? Well, it's me, Ashanti Carter, and I'm the program manager of the Rodham Institute, which is housed at GW School of Medicine and Health Sciences. It's great to be with you today. So as you know, last week we had a great conversation about the ABCs of health insurance. That was part one. So tonight we're going to conclude with the ABCs of health insurance, and we're joined by our esteemed panelists, which our moderator, Ms. Francesca Schillaci, she will go ahead and introduce them, but I want to say a few words about Francesca. She is our esteemed Rodham intern. She is a high school senior from Telluride, Colorado, and she attends Telluride High School, and she has the goal of going into math. I'm trying to steer her into engineering, you know, women in engineering, hey. So I want to pass it on to Miss Francesca. Thank you so much for joining us. Francesca?
Hi, thank you. That was a great introduction. Welcome everybody. I'm so glad people are here and able to make it. So I was very interested. I entered for the Rodham Institute this summer, and I was mainly interested in doing this webinar because there was this young adult in Telluride who was uninsured and making a minimum wage. And long story short, he was hospitalized, and as a result, he is or was $125,000 in debt. So I believe he's still in debt. But long story short, that was devastating to me. How could that happen? How could you just, right when you're starting off your life, be in so much debt? And so my friend and I, John Johnson, we started a nonprofit called Crutches to educate high school seniors about their options once they graduate with regarding health insurance. So that's my story, and that's why I'm here, and that's why I'm interested in learning more about health insurance and also doing this webinar as well. And I will pass it on to our panelist, Professor Sara Rosenbaum.
Thank you so much, Francesca. It's really nice to be here. Just a word about myself. I am a law professor at the Milken Institute School of Public Health. So I work right next door to the School of Medicine, and I actually have appointments in the School of Medicine and the School of Law and the Trachtenberg School as well. So I sort of work at the place where law and public policy and public health all meet up. And of course, I've worked with the folks at Rodham for years, and Dr. El Bayoumi, who has directed Rodham from the beginning, is just a wonderful person. So I'm very happy to do this for her today. So it's my job. Last week, for those of you who watched last week's installment of this two-part series, you heard Dr. Leighton Koo and Dr. Erin Brantley, who went over some of the basics of health insurance, who has it, how you know, the sort of the nature of coverage in the United States. I'm sure they told you that health insurance is absolutely essential to getting access to healthcare, because in this country, healthcare is so very expensive. And really in any country, healthcare is very expensive, but here especially. I'm an insurance lawyer by training. That's what I've done essentially for my entire career. Like a lot of insurance lawyers of my vintage, I didn't start out that way. I backed into insurance law, and I backed into it for a lot of the same reasons that Francesca started her nonprofit, which is I was a legal services lawyer. I represented people who had low wage jobs or who were older and retired and very low income, and they could not afford health care. And so that led me down the path that ended up being the path I've stayed on for my entire career. So my job for the first part of this session is to sort of talk to you about a lot of the issues that come up in health insurance. There are a lot of issues that come up. Obviously, the issue that led to the formation of crutches is sort of the central issue, but there are many others. And what you need to understand about health insurance in the United States is that we live in a country where there are many different types of health insurance. And each type of health insurance comes with its own blizzard of legal requirements. That is just the nature of health insurance law in the United States, meaning that if you're covered, let's say, through your employer's plan, and you work for a private employer, like I work at GW, or Ashanti works at GW, that's one set of laws. If you work for a public employer, for example, if you work for the District of Columbia, or you work for the federal government, that's another set of laws. If you're in the military, that's another set of laws. If you are on Medicare because you've reached retirement age, or because you have a disability, you were a worker with a disability and now you can't work anymore, that's another set of laws. And if you go into the health insurance marketplace, which some of you listening to this might do, and buy an individual policy every year, with the tax credits that the government gives you, that's yet another set of laws. And so there's no single answer to the questions that arise. Now, when we talk about young adults, in fact, are represented in all of these markets, other than Medicare. For them, the market that may be the most important, actually, is the Medicaid market for health insurance. And that's a special public insurance market for people who are low income. They're low income enough to, you can go back to the prior slide. They're low income enough so that their incomes are actually below the tax credit level that gets you marketplace coverage. And in Francesca's example, in fact, somebody working full time at the minimum wage in a lot of states would still have income that's low enough to qualify for Medicaid. So because each type of insurance raises its own set of concerns, I'm going to sort of give you some examples drawn across the markets. I won't talk about the military insurance market so much, but I will give you examples for Medicaid, from the private employer market, from the individual market. So go to the second slide now. So the first question, obviously, is what are you eligible for? Because of where the young man lives, whose plight led to formation of crutches, because he lives in Colorado, or if he lived here in DC, or if he lived in Virginia or Maryland, he would be fortunate, because his income, even if it's low, even if it's below about 1.5 times the federal poverty level is probably about $12,000 for one person, even still, he would qualify for Medicaid. And Medicaid is very comprehensive insurance. If you have to pay a monthly premium, it's negligible. Your cost sharing, your out-of-pocket costs are negligible. And Medicaid has a unique feature that is different from every other form of insurance. And that is that when you apply for Medicaid, you can apply it anytime. You don't have to wait for open enrollment. You don't have to qualify for what's called a special enrollment period. And Medicaid will even pick up bills that you may have from before you applied. Typically, insurance does not do that. Insurance only looks forward. If you are found eligible in August, your coverage would begin typically in September, for example. Medicaid is different. Medicaid looks forward and backwards. Applying for Medicaid is a bit more complex than some of the other systems, although probably not a lot more than applying for marketplace coverage, because you have to qualify based on your family income. So there's an income calculation. Now, if you had employer coverage, of course, You would have presumably signed up at the time you started with your employer. Typically, though, employer coverage is pretty much limited to full-time employees, which might be 30 hours a week. So there may be a lot of people working part-time jobs who can't qualify under the eligibility rules of their employer plan. They would look to the individual market, the marketplace, or potentially Medicaid if they're low-wage workers. There are rules on enrollment. I just mentioned with Medicaid, you can apply anytime. You can be found eligible anytime. You don't have to wait for some special time. With the marketplace, typically you've got to apply, like with Medicare or with your employer, you've got to apply during the open enrollment period. And insurance plans do that in order to keep people from getting real sick and then applying for their insurance, which is known in the insurance business as adverse selection. Medicaid, because Medicaid is a safety net program, it opens its doors at any time, but regular or the other kinds of insurance do not. You can only apply at certain times. You can only enroll it at certain times. Coverage, of course, is a huge issue. What are you covered for and for how much? And even if you're covered for a benefit, will your insurer pay for that benefit? Is it medically necessary? So for example, you might be covered for laboratory tests. Not too long ago, I had a series of laboratory tests and I was covered for laboratory tests, but the insurer required evidence. One of the tests was sort of an unusual test, I guess, and the insurer wanted evidence from my physician that the test was medically necessary. So the physician had to file additional paperwork. So just because you opened up your policy or what's called your summary plan description, the SPD, just because you open it up and says you're covered for lab tests doesn't necessarily mean that every lab test you get is covered. Not every physician visit may be covered. You may be covered for surgery, but still the insurer is going to want to know that a particular kind of surgery or physical therapy or anything else listed in your SPD is medically necessary. And I would guess that 99% of the court cases that have to do with insurance have to do with coverage. You know, it's a fight between the covered person and the insurer, public insurer, private insurer. The individual is complaining because he or she was denied coverage, typically because the service isn't medically necessary. Cost sharing. What do patients owe? So for example, in most insurance plans, and this is where Medicaid, as I noted, is quite unique, but typically in insurance plans, you have to meet a deductible, the amount that you have to pay for your covered benefits before the coverage begins. If you need a benefit that's not covered at all, typically that doesn't even count toward the deductible. The deductible is only the costs that related to benefits that you are actually covered for. And then when you what's called exhaust or meet your deductible, you often would face a copayment, meaning you have to pay a share of the cost. Typically, it might be 20% of what's called the allowed charge, the amount of money that the insurer pays. So if your doctor charges you $200 and the insurer allows $100 and you are in what's called an 80-20 plan, you would pay $20 and the insurance company would pay $80. For most of us, there's what's called an annual out-of-pocket maximum. There's a maximum amount you can be asked to pay in any given year. For Medicare beneficiaries, there is not. So next year, when I switch over to Medicare, when I retire, I will have my Medicare, but Medicare in some respects is not as good as private insurance. It doesn't have an annual out-of-pocket maximum payment, which means that a lot of elderly people on Medicare really face high medical bills, higher potentially than the working age people face, which is sort of ironic since typically their income may be a bit lower. And most elderly people for that reason buy supplemental insurance coverage to sort of wrap around Medicare. One of the things about the modern insurance system is what's known as provider networks. When I was a young person, I had an insurance card and I just went out and used my insurance card. I had Blue Cross, which is a common form of insurance, and I took it to any one of the gazillions of participating doctors in the Greater Washington, D.C. Blue Cross plan, and I presented the card, and of course they then billed Blue Cross. That's not the way insurance works anymore. You have a network. So my health plan, which is the GW health plan, allows me to use, and I use our medical faculty group. So I use Dr. El Bayoumi's services and her colleagues' services. And it's a wonderful medical practice group. And luckily for me, the GW plan includes all of our own doctors. But not too long ago, my husband needed a service that the GW doctors don't offer. And I'm now in a big fight with the insurance company because, in fact, there was nobody in our area who offered this service. We had to go what's called out of network for the service. So now I'm fighting with them to cover the bill, even though I had to get the service from an out of network provider. So staying in network is important. It's also important because you get the benefit of the special discount rates that the insurance company negotiates with its provider network. So a provider who might ordinarily charge $300 for a visit might only charge in network $150 for that visit. So essentially it's a discounted cost, which is very valuable when you're trying to meet your deductible, for example. And it also limits the size of your copayment. Insurers face their own issues, and I'll leave this for Keith to talk about. But for example, is the insurer licensed to sell products in a particular area? You know, can they do business here? And what do they have to do to qualify for a license? And which markets can they participate in? A lot of insurers, like especially the big insurance companies like Aetna, may be in the large employer group market, the small employer group market, the military market in our area, the military health system market, the federal employee market, the Medicaid market, the Medicare market, the individual market. There are a gazillion different markets, and one company may have divisions for every market. And finally, there's a question that is a huge question for lawyers, which is if you are unhappy with your insurer, if you have a disagreement with the insurer, can you challenge the insurer's decision? And in the United States, virtually every form of health insurance allows individuals to appeal a denial of benefits. That is very important for people to understand. It's a long process potentially to appeal on a claim, but very, very few people take advantage of the appeals process. Generally, if you appeal, the insurer is inclined, unless it's a very, very rare situation, to work out an arrangement with you. Like I appealed this question of my husband's need for care, for which we have no in-network provider, and they're going to pay for a portion of the care my husband received. So those are some of the big issues. And why don't I turn it over here to Keith?
Hi, thank you, Professor Rosenbaum. So, not sure where you want me to start. I don't have any prepared slides. You covered quite a bit. I can talk through everything from, how the provider networks work, how people get coverage. But let me just start off with, I work for a Medicaid managed care organization. So Professor Rosenbaum was talking about that as one of the players in this industry. I oversee what I would call our community outreach and community relations area. And we spend a lot of time trying to help our existing members, we sometimes call them enrollees, figure out how to navigate the healthcare system. So just because you actually have benefits and coverage, one of the big challenges can be actually accessing that and learning how to use it and understanding all the terminology. You could run into challenges when you go to the doctor with your ID card, or running into something that I'm sure Professor Rosenbaum knows about, balanced billing, things of that nature. So in Medicaid, and I do a healthcare 101 for some of our folks that come on board, because I've worked in commercial insurance and lots of other areas in health. The whole premise, at least in the district, is that the people that fall below that income structure that become eligible for Medicaid, they don't have any out-of-pocket cost to the doctors that they go see. They're expected, and they probably would be turned down if they were to go to a doctor that was not already contracted with the plan that they're in. So in the case of AmeriHealth, all of our enrollees have access to the doctors that we contract with. If the enrollee was with a different insurance plan, they would have access to those particular doctors. The reality is, in Medicaid, in a place like the district is very small, most of the MCOs, the managed care organizations, have the exact same network. So where does the challenge come in financially? Let's just say the beneficiary, or the enrollee in this case, was out of state and they went to the ER. And when they went to the ER, they didn't actually have their ID card with them. So you go in the ER, and there's this thing called Intala and a whole thing where they've got to provide care for you regardless of coverage immediately at that point in time. After they've triaged you, they've started assessing you, they're supposed to collect the information. If you did not give them, and you were on Medicaid, your insurance card, they have your information. They're going to send you a bill at that point. And you're going to be thinking, well, I shouldn't be getting a bill because I have insurance coverage, but they don't know who your insurer is. And that bill now has to make its way to the insurer. So these are some of the pitfalls that can come up in that area. I'm trying to be a little structured about this. I'm just thinking of things that Dr. Rosenbaum talked about Professor Rosenbaum, Dr. Rosenbaum talked about that I could speak to. Another challenge that people may not be aware of when navigating the health insurance system is, and I'm going to go a little bit away from Medicaid for a second, this concept of a copay and co-insurance. We talked about deductibles. Most of the time when people go to the doctor, whether they have employer insurance or they bought it on the exchange, they assume they went to the doctor, they've got to pay $25 or $40 or $10 for that copay. There's another piece of that bill that the insurance company is paying. And this gets into that whole allowed amount piece. But if you didn't have insurance, and this is why it's so important to coverage, when you walked in the door, the actual visit for a sick visit to, say, an ear, nose, and throat doctor is probably going to be about $120, $130. And that's actually the price that the insurance company has negotiated with that doctor for that service. And then the insurance company works with the employer that bought that insurance for its employees to say, here are some options you can present to your employees where the employee will cost share in those visits, right? So when you go, or one goes and pays $10 or $20 or whatever that copay may be, that other piece is being paid by the insurance company. If you don't have insurance, then all of that money would theoretically be coming out of your pocket. And as Professor Rosenbaum talked about, it could actually be a lot higher because there wasn't a large insurer negotiating that rate of $140 for that visit. That visit could actually be $200. Now, the reality is a lot of providers and doctors and people that perform those services, they tend to be somewhat sympathetic for people that don't have insurance. So hopefully they're not going to charge that higher unnegotiated rate. They're going to actually try to get you the lowest rate that they can, especially if they realize it's somebody in need most of the time. That's been my experience.
Sorry, not to interrupt you, Mr. Maccannon, but this would be a good time to jump into questions.
Absolutely.
That is all right. Okay. So this is open to all panelists. So as COVID-19 has uncovered the need for seeing a primary care physician, do you foresee more people enrolling in ACA or Affordable Care Act? And this is open to anybody. You guys are both welcome to jump in.
Well, in fact, the enrollment is way up. Part of the legislation that passed Congress in the spring, President Biden's emergency relief plan for COVID included changes to the whole subsidy system for marketplace plans. The legislation made the subsidies much more generous. Actually allows people now with incomes below 1.5 times poverty, which would be about $18,000 for one person. The coverage is free. The coverage is no premium at all. There'd still be some co-payments, but the coverage itself is free. And legislation passed in 2020, separate from that, under President Trump, changed the Medicaid rules so that for people who were enrolled in Medicaid back then, a year ago, their coverage just continues without any interruptions until the emergency period is over. And if you come on to Medicaid, since the date of that legislation, you too keep your coverage continuously without interruption. So between the marketplace changes and the Medicaid changes, the number of people who are uninsured barely budged at all. The numbers didn't go up very much because people were able to move to other coverage and because employers figured out how to keep the coverage. But in the marketplace alone, the coverage is up by over 1 million people who absolutely understood that in the middle of a pandemic, you don't want to be in the situation that your friend or the young man you described found himself in.
If I could just add, I would say what we're seeing in DC is there's the federal public health emergency, which extended coverage, but there was also a DC public health emergency. And the challenge that many people are going to face is so without getting complicated, there's another insurance project in the district called Alliance. And because the DC public health emergency ended, there's going to be a reevaluation of
people fell off
eligibility. So we anticipate a fair amount of people losing eligibility in the next 60 days. And then when the larger federal piece is public health emergency ends, there's still people are trying to get their handle around what is that going to mean for people that they may still be below the income thresholds, but they may not have taken all the steps necessary and everything
to renew their coverage.
So we anticipate a significant hit in terms of.
Oh yes, it's a really important point. And in fact, I've done a lot of writing about this problem. I mean, Keith is living the problem. I write about the problem, and the concern is the amount of help that people are going to need when the whole process of renewing your coverage starts up again for public insurance, and they've sort of gotten used to not having to renew their coverage. It happens once a year in the Medicaid market typically. And suddenly people are going to be walking in, or in Keith's case, they're going to think they're still members of the plan and they're not members of the plan anymore. And so everybody's sort of scrambling the hit could be millions of people across the country. And everybody's trying to figure out, how do we stop this from happening? In the states that have pretty liberal Medicaid rules like DC or Colorado, a lot of people, as Keith points out, will remain eligible. They just have to renew their coverage, okay? But in a state like Texas or Florida or South Carolina, a lot of the southern states where the Medicaid rules are very restrictive, when they come up for coverage renewal, if their continuous coverage protection went away, the chances are they're not going to be eligible anymore.
Wow, that is crazy to me.
Yeah.
Um,
This is what happens in a country, you know, we've made great strides, but we're still a country without universal compulsory health insurance, only for Medicare beneficiaries. Do we have the kind of system that you have in Europe where everybody is just automatically, I mean, you're just a member of a plan and you're covered and you pay for it with, you know, your employer contributes, you contribute, taxes, government contributes, and you don't have to wake up in the morning and wonder, do I have health insurance? You've got it.
right, right. Well, I suppose I'll move on to the next question, and that is, there are some businesses that are slowly coming back. How will the pandemic impact their employees' health insurance? Will they have to offer their employees a less than stellar health benefits package?
You know, I don't know, Keith. Yeah, I know you're in the public insurance market, so you're not in the employer market per se. And like, but
I've
I've
worked
been there.
across
Yeah,
commercial
yeah,
and provider, so it's really hard to say. I mean, I don't. So they call it the shop market for small businesses. I'm not really sure. I haven't been reading a lot up on that lately because I am working mostly in the government healthcare space. I would suspect that because many employers are struggling, some of the small businesses, they're probably gonna not opt to offer health coverage through the shop marketplace, the small business marketplace through the exchanges. But I really can't speak to intelligently to how that's going to pan out. But just given how much they're struggling and the costs associated with that, I would think that they would not. I think that would drive more people to the individual market on the exchange. Is probably what's going to happen there.
yeah. You know, I was talking with a friend the other day. I've been at GW for almost 30 years now. And when I started at GW, my health insurance had what's called an actuarial value of probably close to 95%, meaning that every dollar of healthcare I used, essentially the insurer covered 95 cents. Okay, unbelievably generous. Today, my insurance plan has an actuarial value of 80%. And that has nothing to do with the pandemic. I mean, Keith is absolutely right that the economic hardships of the pandemic have made everything harder for employers to offer. But what's really going on in healthcare in the United States, what's really causing this erosion in our coverage and the bigger deductibles and the bigger copays, is that the underlying cost of healthcare is so expensive for people who are interested in this. There are some incredible resources. The Commonwealth Fund, for example, which is a big national charity that does a lot of health policy analyses. The Commonwealth Fund every year puts out an international comparison. And they show you, for example, what getting an MRI, a special, diagnostic test, what an MRI costs in another country versus what it costs here, or what a colonoscopy costs in another country and what it costs here, or having your appendix out, or anything, lots of different procedures. And you cannot believe the differences. And, people say, well, it's because we use a lot more healthcare. No, Americans actually use less healthcare. Well, it's because the government is really strict on what it pays for. Actually, no, their coverage is they cover the same basket of stuff we cover in this country. The difference, according to experts, is the price of medical care. And the price of medical care is very high because it's so expensive to practice in the US. And because we don't have everybody insured, which means a big group practice like the medical practice group that Dr. El Bayumi is in has to charge people like me more money to offset the lower fees they get or the uncompensated care they provide elsewhere. So there's a lot of what's called cost shifting. So the real problem in the United States when we talk about insurance is not so much COVID, It is that we've failed as a country to get a grip on the cost of medical care over a long time.
Gotcha. Wow. Yeah, I am learning so much in this webinar. This is great, actually. And then my third question is, last week we spoke about Longhaul Syndrome, which are people who suffer from long-lasting health ailments due to COVID-19. How will they be covered if they need surgery or continuous medical care?
Keith, are you seeing a lot of long haul cases in the plan yet?
No, I mean, I don't know if we're seeing them. We don't have, and I don't know if there's a specific diagnosis for that yet. So I don't think we really have the ability to discern that just yet. I think it's a bit early, but I do think that will. So I'll speak broadly to just what's going on with COVID. So, and I guess it's probably it's a sensitive area for me to go into, but I would say the health insurers during COVID, a lot of people were not seeking care at the rate that they were seeking care previously. So you might think that healthcare expenditures in the country went way up during COVID. It actually went way down. So right now, in many cases, just like you may have seen with car insurance, right? I know I got some money back from Geico, and some people got money back during the shutdowns because we weren't driving, but you've been paying those premiums. The challenge we have in healthcare and with the market, the way it's, we have this intermediary insurance company being the payer. Insurers have been paid premiums, but healthcare costs, expenditures went down, but they're now starting to rebound in spades, right? So you've got kind of a mismatch of situations. So like, let's just say somebody was going to the doctor regularly for their diabetes or their hypertension or what have you. And for a year and a half, they didn't go to the doctor, but they should have. And maybe they were taking the same meds they were always taking. But now when they go back, they've got more complications. So now their illness acuity and other things are worse than they were. And it's probably going to lead to more healthcare problems down the road, which are going to be more costly. So there's a real, I guess, uncertainty about just healthcare costs in general right now.
Yeah, no, this question, there's absolutely the issues that Keith is raising. And as far as long haulers go, he's absolutely correct, of course, that we are only beginning to understand what the cluster of conditions is that fall into long haul COVID. And so today it may be that, for example, people who are left with tremors, let's say, tremors and conditions that sort of resemble Parkinson's may be treated as Parkinson's, and yet what you're really looking at is long haul COVID. And I think that because medicine is just beginning to understand what COVID might trigger, it's going to be a long, long time before we know whether the complications are more likely to be seen among COVID survivors. There is an organization called Fair Health, and Fair Health is the biggest repository of insurance claims probably in the world. And one of the things that Fair Health is using, it's the repository for insurance claims, and it serves the insurance companies. They need a repository of their claims so they can look at what the prices are they're paying and keep track of their spending. But the anonymous data that are on the claims are a treasure trove of information for people, researchers. And so I have no doubt that we're going to see many, many studies using things like claims data related to COVID patients to start to look for patterns. You have the acute phase, like your friend in Telluride, a long immediate hospitalization, but then potentially a couple of months or even years of post-hospital health conditions. And the way we'll understand it is through research, and that research, a lot of it's going to be done by clustering insurance claims and looking for patterns. But a lot of those conditions are conditions that an insurer would cover anyway. I mean, if you have Parkinson's, the insurer covers Parkinson's. If it's related to COVID, it's Parkinson's related to COVID.
Okay, gotcha. So that makes sense.
They wouldn't exclude it because it was triggered by COVID. It's still Parkinson's.
Right. Okay, that makes sense. And then the next question is, how can we use health insurance to be one of the vehicles to drive health equity? And then after that, I have a sub question for Keith as well.
Well, I mean, I'll take the first part really quick, and then I'll let Professor Rosenbaum weigh in.
Sarah, call me Sarah.
Yeah. So thank you, Sarah. We spend a lot of. I mean, I think we're very focused in the Medicaid field, especially here in DC. It's all about health equity and just making sure that not only those that are disadvantaged from an income perspective, but just from any other underrepresented minorities and other underrepresented groups or groups that may have been marginalized, that they're getting fair and equal access to healthcare. I'm sure in many of the panels, even Rodham's put on, there's been talking about health disparities in things like maternity, mental health, heart disease. I mean, I could go on, where sometimes because of the access that people have, and when I say access, there's sometimes issues where providers may not accept Medicaid. So some of the beneficiaries, the enrollees, may not have access to some of the top providers. And then you have other situations where we've heard this from some of our members, where they may feel that they get treated differently when they go to the doctor because the doctor's treating them differently because of their race, ethnicity, and the fact that they have Medicaid. So they've decided to accept Medicaid. And again, I can't say definitively that's what's happening, but that's what's happening, right? So in many cases, people, perception is reality. And then there's a lot of data out there around the outcomes. So what do? We do a lot of things to make sure we're providing culturally and linguistically appropriate services through making sure all the materials are translated. We actually are required by contract with the district as a Medicaid managed care organization to actually offer culturally competent classes and trainings for our providers. We try to make sure that like our provider directories and our search tools allow people to search for those type of things, whether the office is disability accommodating and has made those accommodations. The website are prepared for people that may be visually impaired, and documents. So there's a whole plethora of things that are going on in that area around health equity. But I think probably the word that probably embodies it all the most, and I think Sarah can speak to this as well, is access, right? The real issue, the first issue is coverage, right? To get you access to healthcare. Because I used to wonder when people said, even today, if somebody says you work in healthcare, well, you work in health insurance. But the reality is, without insurance, you really don't have healthcare. I want to give another plug. So when I talk about when the Affordable Care Act and Obamacare was first being debated, and I think that what I felt, there were some really disingenuous arguments being made on the side against any sort of expanded coverage, is that, well, we have the ER, right? And the reality is, before Obamacare, and probably even still today, if you get a diagnosis of breast cancer and you don't have insurance, I'm not going to say you're dead, but you have a much higher chance of not surviving because of the administration that you're going to have to go through to get coverage is going to delay your care. And any delay with a cancer or anything serious like that is a life-threatening situation. So you can go to the ER. Let's just say you need dialysis, right? they're going to dialysize you. This is I won't explain the procedure, but it's a very important procedure for taking poisons and other things out of your body. They're going to do that in the ER on an emergency basis, but you can't do that every day in the ER. You can't get chemotherapy in the ER. So there's a lot of things that the average American probably doesn't understand or realize when we talk about this health insurance. So for me, it's always been kind of crazy how we provide food services in some cases for people that we won't provide healthcare to. It's almost like we really haven't really thought things through very much in terms of public policy, because the debate becomes a little disingenuous, and some of it, for the people, I think that maybe I'll just give them the benefit of the doubt. They don't know any better. They're not asking the right questions, but I think some of it is just a disingenuous debate often.
Yeah, I would just know, I mean, I couldn't agree more with Keith that in this country, because of the cost of healthcare is health insurance. If you don't have health insurance, you cannot get in the front door. You may get the odd emergency room service. And I should note, Keith points out, the importance of EMTALA, and EMTALA is very important. EMTALA is actually very limited law. When I teach health law, we start with EMTALA, and we look real closely at EMTALA. When you get down to it, what EMTALA says is that if you present yourself at an emergency department, somebody's got to examine you. And if the emergency department decides you don't have an emergency medical condition, you don't get anything. They send you away. And not because they're being mean, but because if you have no insurance, I mean, emergency departments are not there to do urgent care or things that aren't emergencies, but to use Keith's very good example, if you have breast cancer and you presented yourself at an emergency department, of course it's an emergency. In the larger context of things, you're going to die from breast cancer in all likelihood. But it's not it's not the kind of emergency that an emergency department under EMTALA is expected to deal with. They're expected to deal with car accidents. They're expected to deal with women in in labor with an imminent delivery, or in COVID, of course, we've seen this a lot, people who are suffocating. But it's no way to get your health care. And so if you look at the uninsured rates in the United States, and I think Leighton and Aaron might have spent some time on this, if you look at who's uninsured in the United States, you're much more likely to be uninsured. And you're much more likely to depend on government insurance if you're a member of a racial or ethnic minority group, which is why how Medicaid performs, how Medicare performs, how the Children's Health Insurance Program, which is a companion to Medicaid, performs. These are all really important questions for racial equity. I should also note that one of the most important racial equity studies ever done was an amazing landmark study by a researcher named Kevin Schulman, who's now at Duke University. And he took a script. And there was one for men and one for women. And there were, as I recall, 8 people. And this was done with a group of doctors. In fact, he went off to, I think, a conference of internal medicine physicians, and he asked for volunteers. And the physicians were all kinds of people. And the patients, it was a simulation exercise, and they were asked to assess the patient and give their diagnosis, a preliminary diagnosis, and what would they do next. And lo and behold, what turned out to be the case, and everything was controlled. The patients were equally insured. They had the same jobs. So 2 people would be school teachers, 2 people would be insurance executives, whatever. Invariably, African-American patients were diagnosed at a lower rate of intensity, meaning that they were not assessed as needing specialty care, and they were referred for specialty care far less time. They described their symptoms the same. I mean, this was a script, so it was very controlled. And compared to men, even minority men, the worst outcomes in terms of just missing the condition and not referring were minority women. And it's an incredible study because what it shows you is that even well-intentioned physicians, when presented with the same patient, the same presenting condition, the same characteristics, everything the same except color, reach different decisions about how significant the health problems being described were and whether the patient should see a specialist. Now, one could say, well, seeing a specialist doesn't say whether it is that's good. It may not be good medicine to see a specialist, but under these conditions, the expected response from the physicians would be, that's a serious problem. You probably need such and such and such and such a test. You need a cardiac catheterization. And only certain patients got referred for that. So there's something that goes on in medicine. The Rodham Institute, of course, is designed to deal with this. Dr. El-Bayoumi is somebody who's spent her life worrying about this, along with other physicians at the practice. There's something that happens in medicine that has inequity in it, even when you hold everything else constant.
Wow, that's crazy. And I'd like to mention that the study that Professor Rosenbaum was mentioning is linked down below as well.
Oh, you have it. Yeah, there it
Yeah.
is. Yes.
Yeah.
A real landmark study. And one of the more interesting things is the blizzard of outrage it triggered. Oh, the responses. Sure. So it's worth looking at the study. It set off a firestorm. You can imagine the firestorm it triggered.
Yeah. 100%. And I just have a follow-up question for Keith, which was a bit ago, but how does adverse selection and provider contracting impact enrollees, especially those enrolled in Medicaid?
Yeah, so wow, so it's a lot there. I would say it kind of goes back to the access issue that so in DC we've had situations where so I'm going to describe what adverse selection is in a very real sense. So let's just say there are two insurers in a marketplace, and one insurer has a contract with a specialized group of specialists and a hospital system that's prestigious. And then there's another insurer that doesn't have that provider network, those providers in its network. So if you're a person picking insurance, you would probably want to have the insurance company that has the doctors that have the most expertise, right? So if one of the providers is if one of the insurance companies is the only insurance company that has those providers, that's going to make it so that anybody who has significant illnesses choose that particular insurer. So it stands to reason that the costs for that insurer are going to be higher because they've attracted a clientele with a higher acuity, with more illnesses and higher acuity rates. So now you have a challenge for an entity like, say, the state or Medicaid, or who's actually funding that program, where now they've got a mismatch in how their dollars are going across to the plan. And then in insurance, what you have is a situation where with laws of large numbers, if one of those insurers is not able to keep an adequate number of beneficiaries, now they're getting really small, the other plan is getting really big, but one plan is losing a lot of money, one insurer, the other insurer isn't. The marketplace doesn't allow for that to quickly be corrected through the natural means of the marketplace, right? Normally you want things to just kind of work themselves out in a capitalistic kind of way, but that isn't naturally going to happen if there's some deliberate action in the market that creates an imbalance. So you hear things like universal contracting, like DC put some things in place like that, because several years ago, a few years back, there was a situation where one of the Medicaid plans was affiliated with top specialists in hospitals and the other Medicaid plans weren't. And that created a problem, not only for the insurers, that's the business side of it, but the bigger issue, it creates an issue for the Medicaid patients, right? Because now they're confused about where they can get care and where they can't get care. So when you sign up, the average person doesn't really understand insurance even at the level that we're talking about. So you would assume if you have Medicaid that you could go to any of the doctors in the general area where you go. But then imagine if you had Medicaid and you found out, well, that doctor in that hospital, you don't have access to that, but you want to have your baby delivered at that hospital.
Right.
But your doctor can't proactively schedule you for a delivery at that hospital because you don't have that doctor in your network. Sorry, you don't have that hospital in your network. So then you're left with, well, I know what I'll do. I'll just go there through the ER. Well, that's obviously less than ideal, right? So it creates a dynamic. This is where back to, again, what Sarah was saying. Insurance is so important because it really defines the access point for the patient. And then the second that gets a little bit out of whack because of profit motives and other things that are happening at the business level, that has a detrimental impact on patients and care and the timeliness of it.
And if you have anything to add on, Sarah, you're more than welcome to.
Oh, no, I mean, I think Keith explained it great. The strength and the problem with modern insurance products is that you're not just covered anymore. You're covered for a specific group of doctors, a specific group of pharmacies, a specific set of hospitals, specific laboratories. It goes on and on and on. And so when you're weighing which plan to go into, you have to consider where you want to get your care, not just whether you're insured. And most people, luckily, most of us are not sick. So in my own family, when my husband became seriously ill earlier this year, we were for the first time having to deal with a set of health problems that we had no experience with. Well, luckily, we happen to be in a plan that has a great network. But, you can pick by your primary care doctor, which is very important. But that's hardly the beginning and the end of it. So the important thing is to make sure that networks are open so that people can go to the best people and the best specialists in the field when they need them.
Of course.
And just to build on that, so you have the adverse selection where, say, there's one insurer and you pick the wrong insurer. But just imagine if none of the insurers have access to a top specialist or a top group of specialists or a top hospital. Now you essentially have a two-tier healthcare system, right? Where, people probably think that already, right? I mean, I think that's where the disingenuous arguments came out with Obamacare and other stuff that, oh, well, I don't want my access to be diluted because now if the low-income folks have access to the same doctors, so you kind of create a dynamic where because you have this special insurance, you can't get to the top doctors, right? And Medicaid is really designed to make sure that doesn't happen. But again, there's still a lot of voluntary.
Sure, a lot of picking and choosing.
Yeah, a lot of picking and choosing on the provider and the insurance world around how those activities are going to take place because they're working through private companies. Gotcha. Which is why you've heard back in whenever the elections come around, people start talking about public options and things of that nature, because the idea is to really take a lot of that choice, not the choice from the consumer, but the choice of the businesses in the market about who they're going to work with and who they're not going to work with. Right.
Yeah. Well, that is a wrap to the webinar. This is very engaging and I loved it. So thank you
thank you for having us.
Yeah, of course.
Bye. Nice to meet you, Keith.
Nice to meet you.
Bye, Shanti.
Goodbye, everyone. Thank you so much. And join us next time as we discuss various topics for our Rodham Impact Speaker Series. Thank you to Francesca. Thank you to Professor Rosenbaum. And also thank you to Mr. Keith Maccannon. You guys can hear me, right?
We can.
Okay,
Yes.
all right.
Thank
Perfect.
you.
All
Good
right,
luck,
take care.
Francesca, with your foundation.
Thank you so much.
Bye.
All right,
Bye-bye.
thank you, everyone. Bye.
Take care. Bye-bye.